So the infant skeleton is not fully ossified at birth. So it's really flexible. It's very porous. More flexible and more porous means that they can absorb more shock, and their bones are more likely to bend rather than break. And they can, because the periosteum is really thick, they can absorb a lot of force. Um, this means because they're able to bend instead of break, fractures in children under a year of age are really, really rare. So when they come in, you have to carefully evaluate them for abuse or an underlying medical condition. Bone healing, they have a rich blood supply, so they're able to heal a lot faster than adults do from a break. They produce their calluses more quickly, and the younger the child is, the faster they're able to heal from a fracture. This is a picture showing you a representation of the growth plate, which is in between the epiphysis and the metaphysis of the bone. The epiphysis is the end of the long bone. This is a bad place to have an injury occur or break because we do affect their ability to continue growing. Um, in infant, the change here is that, or not the change, but the difference is that the epiphysis is more cartilage, and it gets harder and harder and harder, and it ossifies over time. In children, the epiphysis is ossifying, um, and the physis, which is the space in between, or the growth plate, it's structurally weak, so it's really vulnerable to injury. So any force that's applied to the epiphysis can fracture the bone, and then injury in that area is going to result in only a partial closure, early closure, or an incomplete closure of the growth plate. Um, in a normal healthy child, androgens that occur in adolescence, they cause the growth plates to fuse slowly. So this is what we call bow legs and knock knees. The actual technical terms are genu varum for bow legs and genu valgum for knock knees. These are positional alterations. Um, the bow legs is more common in infants and toddlers, and we really notice it when they're standing or they start to walk. Um, this usually does resolve itself by the time they're 2 to 3 years of age, but if it's still occurring after age 3 or gets progressively worse, they might need some sort of assistance with this or surgical correction. Knock knees, this can be normal until they're up to 7 or 8 years of age, and then can be corrected on its own, or it can be corrected surgically. Um, if it causes the child difficulty prior to age 7 with actually ambulating, or the way that their gait works, we might consider them for a surgical option. It is important to educate the parents about the fact that both of these conditions will self-correct, likely, um, but they need to be aware of difficulty walking or mobilizing, and then surgical expectations, what to expect before and after surgical procedure is done if they choose to go that route. Fractures. The most common cause of an unintentional injury in a child is a motor vehicle accident. The rest of the time, we got running, skateboarding, climbing trees, sports. These are all common areas to lead to fracture, contusion, sprain. Adolescents tend to have more lower extremity trauma than toddlers and school-age children. They tend to have more upper injury trauma. Um, the most common type of fracture is in the forearm and the wrist, and this occurs in children very frequently, and it is a green stick or buckle fracture. Green stick, if you can imagine the bone just literally breaking the way that if you broke a green tree limb, it would kind of fray out from the break rather than being a clean break. That's what a green stick fracture looks like. And a buckle fracture, it causes like a knot through the skin. It doesn't protrude out of the skin, but under the skin you're able to feel a knot or see a knot at the fracture. So the growth plate, like we talked about in previous slides, is the most vulnerable area of a child's bone, and that is where they are frequently injured. Spiral fractures, pelvic fractures, and hip fractures are really rare in children. So if we see those, we need to look towards either a muscular condition or disorder or abuse. Some of the complications that we see from fractures are that, you know, they can have delayed union, non-union, or malunion. It's the same in a child as it is in an adult, the different complications that can occur. They can have infection, avascular necrosis. The bone can become shortened because we've messed up everything that's occurring at the epiphyseal plate. They could have nerve injury or fat embolism, and compartment syndrome is emergent, right? Everybody should remember compartment syndrome. If you don't, look it up. Fractures in early life can lead to osteoarthritis later in life. Okay, so let's see. Therapeutic management. We can put most of these in splints or casts. It's pretty common. We don't see a lot of splinted or casted patients in the hospital setting. This is done as an outpatient. If they're going to have an ORIF, which is an open reduction internal fixation, which means we are going in surgically to the bone, re-breaking it, putting it back in place, and then putting internal fixator pins in place. If they're going to have that, they do need to be hospitalized most of the time, at least in the immediate pre-operative period and for a day or two post-operatively. Some children, based on the severity of the fractures and the location, they might need to be in traction. And there's different types of traction. The one that we see most often is skeletal traction. There is force. There's fixators placed inside the bone, and then we are kind of pulling on it from the outside. It's not comfortable. We do a lot of pain management with those kids and a lot of developmental interventions because they are stuck in a very specific position for a long time. So we don't want them to fall short on their developmental milestones. Here's some super pretty pictures of really broken bones. And the different types you're going to see: open, closed, displaced, and non-displaced. All right, so in the immediate post-injury phase, we're going to immobilize the limb above and below with a splint. We're going to do cold therapy for the first 48 hours. That doesn't mean we're going to keep cold on it for 48 hours straight. We don't want to cause injury to the skin. So Q20-minute ice packs at least once or twice an hour, sometimes only 3 or 4 times a day. We just want to do cold therapy every 20 minutes or so for the first 48 hours. Never have it on for longer than 20 minutes. We're going to elevate the extremity above the level of the heart. That's hard to do with little ones. They're not always willing to lay with their arm or leg elevated, but we just need to redo it every time we come in the room. Prop them up a little bit more on some more pillows. We do the neurovascular checks with the 5 Ps. It's pain, pulselessness, pallor, paresthesia, and paralysis. We're going to make sure that we administer pain medicine when it's needed, and we do repositioning and distraction techniques. If they have an open fracture, we do have to give them a tetanus shot. So before the application of a cast, we just want to try to calm that child down, keep their pain controlled, and let them have some control over the situation by letting them pick the color of the cast or explaining how it's going to be afterwards and what type of splint they might have to wear, and that we're going to make sure that they are able to control their pain even when they're not in the hospital. We just want to reassure them. After the cast, or while the cast is on, we want to do frequent neurovascular checks. We want to tell the physician if there's any change in that, any drainage or odor from the cast. If the kid is constantly complaining of pain, it might be their skin underneath the cast. So we might need to check that. That's something to let parents know because usually they're going to be outpatient with that cast. We're going to position the kid with the extremity elevated up on pillows, and we're going to give home care instructions to the family. Part of the home care instructions are that they're not allowed to get it wet. They have to keep it covered if they're going into wet environments. They cannot swim. Usually showers aren't the best idea unless they have one of those fancy little cast covers that closes above and below. Sometimes you have to sponge bathe these kids for the duration, and it's not easy. Remember, casts aren't always on your arms. Sometimes it's a hip spica cast, and you only have a hole in the bottom of it for your genitalia and your anus to be open. So it's really difficult to keep them clean. There are some little tips and tricks to keeping it clean and dry, like lining it with little chucks or wash rags. When they're doing a cast removal, it's really scary. The cast cutter is really loud. Most of the time, we have to tell them that their skin is not going to be chopped open, that the cast cutter is not going to drill into them. It does most of the time. They have ones that are they look like a skill saw, and it's really scary. I did see an adult patient get cut by the orthotech trying to remove her foot cast. And it was a mess. So I can't say that it doesn't ever happen, but they're trained usually to keep it from happening, and they use the appropriately sized cast cutter. So we do need to explain to the kids that it's going to feel warm while they're doing it, so that they don't freak out about it starting to get a change in temperature, and that their extremity is going to vibrate while they're doing the cast removal. And then we need to educate the kid and the family about the fact that that extremity is likely going to be kind of wasted looking, stinky, pale, and just kind of atrophied overall, and that they might need some, time to build up strength in it again. Okay, when we're dealing with a child that's in traction, we need to make sure that we give them plenty of chances for normal growth and development. If their legs are in traction, we need them to be using their upper body as much as they can. We need to keep their little brains happy and involved and learning, and we need to prevent complications. So we're going to exercise everything that's not affected. We're going to have them use a trapeze to be able to help us with their movement, because we need to keep them strong and engaged. And we need to encourage them to do some deep breathing and coughing, because we don't want them to get what? Pneumonia, atelectasis. We want to promote their normal growth and development with age-appropriate toys. We want to let their friends come and visit them. We want to use little iPads and tablets and give them lots of diversions like video games and coloring books and drawing. Sometimes I will have like competitions with them and see who can draw the thing the fastest, stuff like that. I have my entire nursing career never taken care of a child in skin traction. I've not seen it done, and I don't know how often it is done. But we are attaching weights to them to kind of pull on the extremity. So with all of these, skin traction and skeletal traction, we want to maintain the skin integrity, and we want to make sure that we do frequent neurovascular checks because obviously we can see problems ensue from swelling and obstruction or just the injury itself. So we want to make sure we watch that. Skeletal traction is when they're applying weights with ropes that are attached to pins that are literally placed in the bone. We do frequent neurovascular checks on these kids. We're looking for the 5 Ps. We treat the sites where the pins are inserted into their bone as a surgical wound. So we're going to watch for infection. We're going to do daily pin care and teach the parents how to do it at home as well with chlorhexidine or with a normal saline solution and like a little cotton bud, and you're cleaning around the pin and assessing it for infection or slippage of the pin. Those are things we want to notify the doctor about. And you want to let them know what the signs and symptoms of infection are. So in the hospital, just overall for any child that's in a type of traction, we need to make sure their alignment is good. If they're too close to the traction, it doesn't pull. So we need to we're constantly repositioning these children farther up in the bed. We want to maintain all their bony prominences as well as we can. No pressure, no skin breakdown. We want to check them frequently. The backs of the head, elbows, sacrum, these are common places to get skin breakdown. And I frequently see it that people don't assess children and infants the way that they do adults because they think that they're just, perfect skinned little beings. They can still suffer from the same skin breakdown in the same amount of time. We look at the temperature and color of their extremities. We look for neurological involvement, if they're having numbness or tingling. And then every 15 minutes after we apply traction, we want to do neurovascular status checks up to an hour. And then we change it to every 4 hours if they're stabilizing. We want to make sure that the area around the pins, if they have internal pins, that it has some loose gauze around it after the sites have been cleaned to try to prevent contamination or infection. We're going to do good hand hygiene, and we're going to make sure that the bed's in a low position, the side rails are up, that this kid has the ability to reach all of the things that they need to reach. We need to make their little room as comfortable as we can for them. So I hope at this point in your life, everybody knows what a sprain is. It's most common in the ankle or the knee, and it's a twisting or turning motion that causes it. It's just a stretching or slight tearing of the tendons and ligaments. It's really uncommon in younger children because their growth plates are weaker than their muscles and tendons, so they're more prone to fracture than a sprain. We do therapeutic management, so RICE therapy. What is RICE therapy? Everyone should know this. Rest, ice, compression, and elevation. And activity restriction if necessary. It's not likely that we do casts. Most often it's splinting. They can use crutches or wheelchairs, and sometimes they have to have physical therapy. Most of the time, this is a very outpatient sort of thing. You might see these kids in the ED. You're teaching the family about rice, how to use crutches, and when they can return for follow-up, and what they do about school, like PE. How long do they need to be resting? So we'll get the social worker involved to usually give them like notes for school based on the doctor's orders. Congenital clubfoot occurs 1 in every 1,000 live births, more often males than females. It's an inversion of the heel most often, sometimes a plantar flexion of the foot. There's different types of it. There's talipus varus, talipus equinus, cavus, and a forefoot adduction. It doesn't matter. They're all clubfoot. Half of all the cases are bilateral, so you end up having both feet involved. And what I need you guys to know about this is that you have to start treating them as soon as possible after birth. They do weekly manipulation of the area with casting and then serial cast changes every 2 weeks. Because they are more pliable and malleable at this age, we're able to manipulate the area with casting and not have as many kids needing surgery. There are some infants that require a surgical release to kind of loosen up the soft tissue, and then they're immobilized for about 12 weeks, and then they wear corrective shoes. But so for you guys, congenital clubfoot, you have to start treatment as soon as possible after birth. Osteogenesis imperfecta, it's genetic. They have decreased bone mass. The bones are very fragile. They do have connective tissue involvement usually, and can have some other organ involvement. I'm not going to go over the pathophysiology of it. I just need you to know it can be mild, it can go to severe, it can affect all of the connective tissues or only the bones. We call this also brittle bone syndrome. So the diagnostic testing, maybe they'll do a skin biopsy to see if there's abnormalities. They're going to do DNA testing. The therapeutic management of osteogenesis imperfecta is a medication that we call bisphosphonate. A lot of OI, or osteogenesis imperfecta families, call this bone juice. They go and get these infusions of bisphosphonate every so often throughout their lives. It's given at 4-month intervals via IV. There are some side effects if they do it orally, like heartburn, regurgitation, discomfort. So IV's a better way to go. These children, we usually teach parents how to do fracture care at home. If they had to bring their child into the hospital every single time they had a fracture, they would never leave. These kids do have a lot of PT and OT so that they don't have develop contractures, and we try to maximize their mobility by providing them with braces and positional aids. Sometimes they have wheelchairs or walkers they can use to really help them out to be able to participate in activities like other kids. For some severe cases, they will do surgical rod insertions into the long bones to try to straighten them out or provide more stability. So the nursing management of these children is to handle them really carefully. We don't want to squeeze them, pick them up wrong, grab them by their arms and help them get up because we're going to break something. Usually the family, by the time they're able to see us in the hospital, they've been dealing with it for so long that they teach us. So we don't want to push or pull on their arms or legs. Swimming is great for these kids because we're increasing the muscle mass around these very fragile bones. We use adaptive equipment as soon as we possibly can. Braces, positioning aids, lightweight splints. We do reinforce that OT and PT are really necessary, and we refer these patients and their families out to OI foundations so that they can contact and be in touch with other families that deal with the same thing, because there is a constellation of issues that these children deal with besides just their bones. A lot of times they will have hydrocephalus as well, sometimes speech or cognitive delays. Sometimes they will have, because there's connective tissue involvement, cardiac or lung issues. It ranges. Developmental dysplasia of the hip. Um, this is just abnormal development of the hip structures. Um, there are risk factors like being the firstborn child that's a female. There might be a family history of DDH. If they are born breech, you can find this happening. Uh, and they're likely going to be large for their gestational age. One of the hallmark signs of DDH is asymmetry of the skin folds on the posterior thigh. So if you have the baby laying prone and you're looking at the posterior thigh area, the folds underneath the buttocks, from the buttock to the knee, if they are asymmetric or if they are unequal in number, that's a good indicator that there might be DDH happening. They do little tests in the neonatal period where you see them bring the knees up to the baby's belly and kind of roll them to the side. They're looking for hip click, and they're doing what's called they're assessing for positive Ortolani test and a positive Barlow sign. So most often they're able to really see that this is occurring pretty early on. So the way that we manage this, if they're under 6 months of age, we want to treat them as soon as possible, regardless. We want the parents to bond with this child, hold them as much as they can, and to meet their developmental needs. But if they're newborn to 6 months, we put them in what's called a Pavlik harness. And as you can see, this little baby on this picture is wearing a Pavlik harness. This harness needs to be in place for up to 12 weeks. We check their straps every 1 to 2 weeks because these little guys are going to be growing like weeds, and we need to make sure we're not compromising their neurovascular system. So we do neurovascular checks and skin integrity checks, and when they take the harness off is very dependent on the progression of the child's recovery. So what we educate the parents for the Pavlik harness is that they're not going to adjust those straps. We adjust the straps, not them. We'd want to teach them skin care by letting them know that they can use an undershirt on the baby. The baby can wear little knee socks, and we teach them how to assess the skin and how to kind of we're going to not put lotions and powders on. You're going to try to keep them as clean and dry as possible, but lotions and powders can be abrasive underneath these types of straps. They're going to put the diaper underneath the straps too. And we're always going to be assessing that skin. So if they're between 6 months to 2 years of age, if this is the point at which they have figured out they have DDH, they often need to have a closed reduction performed, and then either skin or skeletal traction. These kids are put in a spica cast for up to 12 weeks. It is very uncomfortable and very difficult for parents to deal with. I'm going to put a picture or a video of a spica cast up on the board. If they're greater than 2 years old, they do open surgical reductions and then casting after that. Again, these children have to be often in really aggressive casting. Hip spica casts are not an easy thing to deal with when you are potty training or dealing with diapers. And just kids are dirty, so we end up with really filthy areas. After the casting is done, these children are going to need to follow up with an orthopedic surgeon or orthopedist, at least until their skeleton's completely matured. I think that's all I care about with this. Oh, if a baby's in a Pavlik harness, if their feet get swollen or blue, or if their skin starts to get raw or rashy, you have to call the doctor. If the baby can't kick their legs, they need to call the doctor. So these are education tips that we give to the family. We need that baby to be able to kick actively, have no swelling or blueness, and no skin issues. I'm going to give you a quick rundown of leg calf Perth disease. This is something that they test on in NCLEX, but we don't see it very often. This is avascular necrosis of the femoral head. So we don't know why, but the blood supply to the femoral head makes the bone die. They don't know why it's happening. And then the round shape of the femoral head gets kind of lost. Swelling occurs around it, and they get a lot of fractures. So the clinical manifestations, painless limp. They might have mild hip pain worsening with exercise. So know that leg calf Perth disease, they have painless limp. The complications, they have joint deformity, degenerative joint disease, loss of hip motion or function, and gait disturbance, which causes pain everywhere, right? If your hips aren't working right, everything hurts. Therapeutic management for these kids, we're going to try to maintain normal femoral head shape to restore motion. Obviously, we don't get to do that as nurses. That's not something we do, but we provide them with anti-inflammatories. We do encourage the patients to kind of limit their activity as far as walking, running, trying to do too much in one day. Sometimes they need to be braced or casted. And some of the ways that we diagnose this is with hip x-rays, MRIs, or bone scans. Osteomyelitis. This we do see a lot of. It's a bacterial infection of the bone and the soft tissue. It's usually caused by MRSA. Some of the risk factors are if they've had chickenpox that got infected lesions, if they've had a recent trauma or a burn, if they used IV medications for a long period of time. And impetigo is also a risk factor. So the bacteria get into the metaphysis through the tiny capillaries, and then stuff just grows, and we get pus and swelling and displacement and abscess, and then necrosis starts to happen. And once the necrosis happens, it's really hard for us to get in there with antibiotics and do anything about it. So we want to try to manage this early. Clinical manifestations of osteomyelitis, they're going to be irritable, lethargic, feverish, and they're going to have a lot of pain. Most of the time, if it's a leg or a foot, these kids will refuse to walk. You'll be able to lift that blanket up and see the swelling. Literally, the heat will radiate off of it, and it'll be very, very exquisitely tender. Some of the diagnostic workup that we do, we check the WBCs, we look at the ESR and the CRP because we want to look for what? Inflammatory process. We do blood cultures before we start the antibiotics. X-ray and ultrasound. Some of the complications, obviously, the bone can just be destructed. Fracture can occur. They can have recurrent infections over time. They develop what's called septic hip or septic arthritis, and then this can lead also to sepsis. Some of the management, we do aspirations to confirm that there's something in there. Um, and then usually 4 to 6 weeks of antibiotics. Once they can be switched to oral, that's usually when they can go home. There's very few home health agencies that do home IV antibiotic therapy for children. And most of the time, these kids are going to be on triple IV antibiotics. The nursing management, obviously, we're going to maintain their IV access as best as we possibly can. And if they're going to be needing to have long-term antibiotic therapy, which I consider anything over a week to be, we want to get the VAT team or the PIC team involved so that they can come in and place a PIC line. We want to try to keep these kids comfortable and provide them with lots of distraction, age-appropriate toys and games. We want to educate the parents about how to take antibiotics effectively, what the antibiotics we're using do and why we give them. And when they go home, instructing them to really complete that whole course of antibiotics, and that they have to call the doctor for neurovascular compromise, signs or symptoms of returned infection, or pain that's unable to be controlled. Scoliosis. I'm sure that we all remember at some point in elementary school, or maybe they don't even do it anymore and I'm too old to know, having to bend over and touch our toes and show the school nurse that we don't have scoliosis. So this is a lateral curvature of the spine that exceeds 10 degrees. They don't really know why it happens, but it does. It can range from very minimal to very severe, where their upper body is almost completely turned around due to the curvature. So therapeutic management, we're gonna try to prevent the progression of the curvature. So there's screening, which is the reaching down and touching your toes, x-rays to measure how much of a curvature there is, and then the treatment's usually based on the age of the kid and the severity. So sometimes it's just continued monitoring until they're done growing, and then we look and see what might need to be done, if anything at all. If it's a 25 to 40 degree curvature, they might need to have a brace, and if it's greater than 45 degrees, it's usually surgical correction, and then they wear rods, and they have bone grafting with spinal fusion. So for the kids that have to be placed in a brace, we need to make sure that they are educated on how to use that brace. They need to wear it up to 23 hours a day, so they're sleeping in this thing. They get 1 hour off. We need to make sure that they're compliant with this brace use. And it can be hard for teenagers, so we want to give them maybe some ideas or guidance on how to find, kind of cute baggy clothes that they don't have to show everybody that they're wearing a brace. We want to maybe find support groups that they and their families can belong to, so they can reach out to others that have dealt with it. And we want to teach them how to explain to their friends what's going on with them. We're going to educate them on maintaining their skin integrity. It's hard when they wear these braces to keep their skin clean and dry. They're going to wear t-shirts underneath the brace. And we also want to teach them how to exercise to strengthen their back muscles. Post-surgically, pain management is very important. Just anything with bones, pain management is a big deal. Just like with the osteomyelitis kids, pain management is the #1 nursing intervention. We're going to deal with that here as well. So pain management is number one, and then they're going to need to do a lot of follow-up care up until they get to be about 18. Um, so in the immediate post-surgical phase, we give them pain management, we evaluate their skin, their neurovascular status, and then when they're ready to go home, we educate the family about when they can return to school and how long it's going to take for them to get back to a normal activity level. So they can usually go back to school after surgical treatment within 2 weeks of being discharged from the hospital, but they have activity restrictions for up to 6 months. They don't participate in PE or anything that could cause injury to their spine.